Traditionally, we think about, or historically, we think about rotator cuff injuries in the summer months with the throwing athletes, the baseball players, softball players, tennis players. But actually, as we now know, winter is coming. And that does not mean that the rotator cuff tears go away or the other shoulder injuries go away. There are many activities in which we all participate during the winter months that can cause just as much heartache about the shoulder as pitching and playing tennis for long periods of time. This probably isn't one of them, but if we think about the other ones that we'll go through, I'm hoping that I can maybe clear up some of the confusion about, quote, rotator cuff injuries that I see every day in my practice. And I think that the easiest way to do that is to impart some information to you all that will hopefully be helpful. And I think when I teach residents and medical students, we always start with the basics and we start with anatomy. I also think it's important to remember that the primary purpose of the shoulder is to put your hand where it's supposed to be. It's not to beat on things or run into people this way. It's to put your hand where it needs to be so you can survive. If we then look at the different parts of the anatomy, we start with the skeleton and the bony anatomy. The bony anatomy, we look at this part right here. It's the yellow part is bone, and this, quote, ball of the ball and socket joint is the humeral head. This yellow part over here is the socket or the glenoid of the scapula. Up above, you have the end of the collarbone or the clavicle, and adjacent to that is the acromion. So this is the acromioclavicular joint or the AC joint. When somebody says they've separated their shoulder, that's the joint that they're talking about. But the soft tissues about the shoulder are also very important. Sandwiched in between the bone of the ball and the bones up above are a lot of soft tissues. And if we go from inferior to superior, this is the joint cartilage, and then we have the joint lining or the capsule. And right adjacent to that, or on top of that, we have the tendons. Remember that muscles attach to bones through tendons. And then once we go through the tendon, and there's a dimension, there's a thickness to those tendons. There's a surface that we call the joint surface or the articular surface. And then there's the top surface up here. And adjacent to that is this blue structure that's collapsed, which is the bursa. And that's a potential space. And the function of the bursa is to cushion these soft tissues from the bone that's on top of that. And then on the side here, we have the big deltoid muscle coming right down here. And you can imagine that if this muscle, if it's attached here and it's attached down here, and it contracts, it wants to drive that bone, the ball, right up into the bone up in there. And the rotator cuff muscles function to keep that from happening. And we'll talk more about that as we go along. But also, what we're going to talk about in a little bit is if we have a device in here with which we can look into the shoulder joint, you can imagine that if I put my arthroscope in this bursa or the sac here, because of these tendons and because of the ligaments, I shouldn't be able to see that ball. And that's important as we go through and talk about injuries. Okay. We just missed a little bit of an anatomy lesson, but we're going to keep going on anatomy. If we then look at it from another perspective, a patient lying down in an MRI machine, so the back is down here and the front is up here, and now we see the ball up here and we see the socket. And it's analogous to a golf ball sitting on a tee. The ball is much bigger than the socket, so it's inherently unstable. But what that allows is, because there's such a misfit or an incongruency here, that allows you to be able to move your arm a lot more than you can move your hips. Hips are built for stability to get you around. Shoulders are, again, designed to put your hand where you want it to be. And because the bony anatomy is so different here, you can imagine this just blowing off. In your body, you're dependent on the soft tissues to stabilize that joint. We're dependent on the ligaments which are called the static stabilizers. They're just there. They're functioning whether we call upon them to do anything or not. And then there are the dynamic stabilizers, which are the muscles around there. And that's what we're going to focus on tonight. The only way you can really see all four rotator cuff muscles is if you look at it this way, because the biggest muscle of all is the subscapularis, and it's in the front of the shoulder. Notice that all of these muscles in the rotator, these are showing all the rotator cuff muscles, and again, we'll talk more about them in a second. They all start on the scapula, or your wing back here. And then they come out and they go under these bones, again, the end of the collarbone and then the acromion. They pass under those bones and then insert on the top of the ball here. So the subscapularis is the biggest one, and that inserts in the front of the shoulder, the ball and socket joint. The other three, the supraspinatus, infraspinatus, and teres minor, insert on top and toward the back of the ball. Again, muscles attach to bones through tendons. If we then look just from the back, we can no longer see the subscapularis, but we can see the other three muscles of the rotator cuff more clearly. The supraspinatus is up here, then the infraspinatus, and then the teres minor. All of these three insert in the same place on the top and the outside of the ball. And again, their function is to hold the ball centered in the socket to keep the deltoid from pulling it up, and also to help you start your arm out to the side, to give you a lever advantage so the deltoid can then, with great strength, pull your arm up overhead. The other reason I put this in is to show all the other structures that are around the shoulder, the nerves and the arteries, because not all pain in the shoulder or injuries to the shoulder are rotator cuff. There are a lot of other things that can hurt the shoulder, but it seems like most people who come to my office say, I'm sure I have a rotator cuff problem. They're frequently right, but not always. If we then look at a spectrum of injury, starting on the minor end of injuries to the rotator cuff, it's actually not really an injury. It's inflammation of the rotator cuff tendons, in which case it's tendonitis, and inflammation of the bursa, in which case it's bursitis. But remember from the slide we looked at before, they're intimately related. The tendons are coming right in here, and the bursa is lying on there. And if it's not inflamed, it's a potential space. It's like a collapse balloon. But when it's inflamed, you can get fluid in it, and it becomes much more irritated. So an injury is not necessary to cause bursitis and tendonitis. It can just sort of happen in routine daily living. And these are folks who have pain reaching up overhead, because as the arm comes out to the side, it pinches that bursa and those tendons between the bones, and that hurts. The other thing that hurts people is lying directly on it, because if you're lying on your shoulder, sort of the quote point of the shoulder, you're pushing in there also. So you're usually early on, no history of injury, but people have pain reaching up overhead, lying directly on it. And a lot of times I think what happens is, when I see folks who have really lost motion and are heading for a frozen shoulder, the first time they reach up to here and it hurts, the next time they're not going to go quite so far, and the next time they're not going to go quite so far, and it ratchets the motion down, and they really end up losing a lot of motion that way. So the least damaging part of rotator cuff pathology on the minor end of the spectrum is inflammation, tendonitis and bursitis, no injury. Frequently motion will be compromised. Usually strength is okay. It's only inhibited by the discomfort. But again, it's the most benign form of things. If we then talk about tears, not inflammation now, but tears, in terms of the mechanisms of injury, acute, people can usually tell you exactly the day, the minute, and what they were doing when they tore the rotator cuff. It may be a snow coaster, landing directly on it. It may be crashing into the boards playing hockey. It may be crashing into something else. But it's usually landing directly on it, the way the rotator cuff tendons fail. And again, one thing I didn't mention in the anatomy diagrams, the rotator cuff usually tears at the tendons, not within the muscle. And the tendons usually pull out of the bone, where the tendons hook into the bone. That's where the tears most commonly occur. So falling directly on the shoulder, the rotator cuff tendons fail in compression. Or if you plant a ski pole and you ski by it, you may dislocate your shoulder, but your rotator cuff can also fail in tension then. So it can fail in either compression or in tension, an acute injury, 1 day, 1 minute, that hurts. Or you can have many small insults or cumulative trauma in a more chronic setting. Can't really pinpoint the time, but frequently I'll see it in seasonal changes when people go from, say, playing soccer or something in the fall, and then they start playing squash in the winter, or they start cross-country skiing and then go to another sport. But it's sort of as they're ramping up into it, they'll become uncomfortable, get a little fraying of the rotator cuff, not really defined time, but just over a gradual period of time. And then you can also have an acute on chronic, where somebody says, my shoulders bugged me for 2 years, but I also fell, and then it got much worse. Suddenly I couldn't lift my arm up. And that's probably an acute on chronic, and I see it in the operating room all the time. And that can be difficult to address in terms of treating it. And I put this picture in the operating room up just for a reference to a perspective, because we're going to look at some arthroscopic photographs. So for orientation, this is the person's shoulder, their arm, their forearm and hand are in an arm holder. You can see the arm of the arm holder. It's a pneumatic arm holder, so I can put the arm in the position I want to do whatever that needs to do, whatever it is I need to do. The head is back behind these drapes, obviously the back. The person is sitting in what we call a beach chair position. And so when I'm doing an arthroscopy, I'm usually standing facing the shoulder. So I'm looking in at the ball and socket, and the back of the shoulder, in this case the back of the shoulder is to the right, and the front of the shoulder is to the left. And I put the arthroscope in there. Because now we're talking about tears of the rotator cuff as opposed to just inflammation. So the most common tears that are partial thickness tears, in other words, remember I mentioned there was a dimension to the tendons. There's a thickness to them. There's a joint surface of the tendons, and then there's a bursal surface of the tendons. The most common partial thickness rotator cuff tears are on the joint side or the articular side. They're much more common. You can see all this frayed tissue. This should be sort of a really nice linear tendon here. What I'm doing is debriding the frayed part of it there, but there's still some fibers that are intact. The more symptomatic partial thickness tears are on the top side adjacent to the bursa. So what I'm doing here with a probe is, again, I'm standing looking at the shoulder this way. So the back is back here, the front's here, and I'm looking from the side right straight in. And I can see this part where I have a probe in there lifting up that side of the cuff, of the tendon, but there's still some fibers that are intact. I'm not looking at the ball through a hole there, as we'll see in just a minute. Bursal side tears are much more symptomatic than articular side tears. And if you remember one of the first anatomy slides I showed, the tendons of the bursa are sandwiched between bone, the ball of the ball and socket joint, and the acromion, the bone up on top. So when they bring their arm out to the side, this is like a ridge, and it gets caught under that bone. So folks will have what's called a painful arc, where they'll get up to a certain point where that tear contacts where the bone is sticking down, like a spike sticking down. And as they hit that, they get a lot more pain. So those are more symptomatic but less common. Partial thickness tears. If we then look at full thickness tears, again, I'm standing there, so I shouldn't be able to see, if I have my arthroscope in the bursa, these tendons, these are the stumps of the tendons. When they tear, they recoil like a rubber band. So they retract, and they can retract all the way to the level of the socket, quite a distance. So I shouldn't be able to see the ball right here. And the socket is right down here, and here's the stump of the tendons right up there. So that's a full thickness rotator cuff tear. Now these people, the partial thickness tears, partial thickness tears, people may do fairly well with non-operative treatment. They will frequently complain of pain. They may have a loss in range of motion, and they may have a loss in strength if the fibers that are still intact are not strong enough to compensate for those fibers that are not intact. So they may still be doing okay, but uncomfortable. The most common complaint in my practice is pain. So although I'm a surgeon and I love to operate, we always start with the least invasive treatment and go to the most invasive treatment as we need to. Physical therapy is basically the cornerstone for treating rotator cuff pathology that is on the more minor end of the spectrum in terms of the tendinitis and the bursitis and even partial thickness rotator cuff tears. People can do very well with bursitis tendinitis, including the modalities, which is ultrasound, phonophoresis, and iontophoresis. And they may be effective enough in partial thickness tears to keep somebody from benefiting so that somebody can avoid having surgery. If the non-steroidal anti-inflammatory medications and also the modalities calm the inflammation down enough, which is what this is all designed to do, is to decrease the inflammation, to allow people to participate more wholly in physical therapy, to optimize the function of the fibers that are still intact, to compensate for the fibers that are torn. However, that will not fix a full thickness rotator cuff tear. And on the scale of least invasive to most invasive treatment, the next more invasive treatment are injections. Now, the non-steroidal anti-inflammatories, Aleve, Advil, ibuprofen, are designed to decrease inflammation. It's the inflammation that gives you discomfort. So you're taking that systemically. If somebody has tendinitis, bursitis, or even a partial thickness tear, sometimes I'll offer a steroid injection to put the most potent anti-inflammatory right where it needs to be. And the logic there is that it will, again, make you comfortable enough to fully participate in therapy to strengthen or optimize the fibers that are intact. However, there's also a downside to steroid injections. They can weaken the tissue. So I sort of cringe when I see people who say, yeah, I've had 5 injections and I'm not better. I go, because you can actually weaken the tissue, and if you have a partial thickness tear, you can propagate a larger tear. Or if you have a full thickness tear and you're getting injections, you can definitely propagate a larger tear. If a patient comes in and says, I know I have a rotator cuff tear, but I am never going to have surgery, which a lot of people do, and they say, but I'm really uncomfortable, then I will give them an injection with a full thickness tear, as long as they're saying they're not going to think about having surgery down the road. And then if we get to the ultimate treatment, especially of full thickness tears, there are 3 things that I consider when I'm talking to my patients about whether or not to proceed. Pain. And chances are they wouldn't be sitting in my office if they didn't have pain. A loss of range of motion. One of the hallmarks between having bursitis or tendinitis or inflammation is the fact that usually active range of motion will be preserved. One of the hallmarks of a full thickness rotator cuff tear is they lose active range of motion. Some people with a big tear will come in and they can't even lift their arm up overhead. But passively, you can bring their arm up for them, and then they can't hold it there. So that's a positive drop arm test. So range of motion, the loss, we consider they've had a significant loss in range of motion. And then the third thing is strength. If they've had a significant loss of strength, then we'll consider repairing them at that point as well. Again, it's totally patient-driven in my mind. In fact, I spend more time in my practice talking to people out of having surgery than giving them information about having it. So then how do we determine whether or not a tear is repairable? And I think it's very important for my patient and myself to be on the same page in terms of expectations. And it's helpful to go to the objective data after we've done our clinical examination and we have an MRI. X-rays show us bone and they show us relative positions of bones to each other, but they don't show us the soft tissues that we talked about being so important in terms of stabilizing function and helping the shoulder to function. So this is an MRI in that same plane, the coronal plane that I showed the first anatomy slide. So again, here's the ball, here's the socket, here's the acromion up here. Now in an MRI, if you have blood or fluid, there's what's called increased resonance, and on these cuts, it'll show white. So what this shows is that this structure right here is the muscle of the supraspinatus, the top rotator cuff muscle that's most commonly formed, coming out to the tendon, and this tendon is supposed to be attached down here. So the white area of increased resonance here is fluid from a full thickness rotator cuff tear. So we consider, with an MRI on the different cuts, we can determine how big the tear is, how many tears are involved, and we grade those. The more tears involved, the harder it is to repair, and the prognosis is actually worse. Then we talk about retraction. When a tendon lets go, it's like a rubber band and it recoils. And it may go all the way back over here, like the one I just showed you a few minutes ago. So they let go. So tear size, tear retraction, and atrophy. If a muscle's not attached to both ends, you can't keep it strong. And once you have atrophy after the first 3 months or 12 weeks, post-injury, that atrophy is not retrievable, it's not reversible. So the reason to do something surgically then is to prevent further atrophy and to help alleviate pain. So those are the considerations in terms of talking with somebody and saying, I think there's a pretty good chance that I'm going to be able to fix your rotator cuff. And then if we talk about surgical technique, 95% of the rotator cuff repairs I do now are arthroscopic and in the outpatient setting. I hardly ever open with a big incision the rotator cuff navigation. So again, the same perspective. We're standing looking in towards the ball and socket joint. Here's the ball, the humeral head. Here's the stump of the tendon. So it gets stuck to the bone above, the acromion, and it also gets stuck to the socket down below. The first thing I have to do is free it up, both on the top side of the dorsal side and on the underside. And then once I do, this is actually sort of like a spatula almost that I use to go around. This is the socket. So I'm freeing up the undersurface of the tendon after I've freed up the top surface of the tendon. The whole time I'm doing that, I'm sort of pulling on it gently, seeing whether or not it's going to come all the way back out, because these tendons need to be out here when I finish. And that's at least 3 centimeters, maybe 4 centimeters. So once I've freed it all up, then I start to sew it back together. And I tell my patients, sort of like building a ship in a bottle. You have long instruments through cannulas, and you're looking at a monitor. So we pass sutures, we sew things together. So this is sewn together side by side here, but I still haven't anchored it back to where it's supposed to be on the lateral edge of the ball there. And the bone is hard. I can't sew into the bone. So what I do is I put in a row of what are called anchors. This is actually just a punch. We don't want to drill because we don't want bone to come out. We want to compress the bone to screw in a plastic headed screw that sits countersunk below the surface of the bone, and it has these stitches attached to it. This is just the metal introducer here, then I take that out, and then I'm just left with the stitches there. And I have different instruments with which to pass those sutures through that end of the tendon, and then when I tie it, it ties the tendon down where it's supposed to be, and we recover the head. So that's how we do it. And then the work begins. I do my part again as an outpatient, but then people are in a sling for anywhere from 4 to 6 weeks, depending on the size of the tear and the quality of the tissue. The larger the tear or the poorer the tissue, the longer I mobilize them. So it's anywhere from 4 to 6 weeks, but when you come back in 2 weeks, you come out of the sling, bathe and do the exercises, but then go back into the sling otherwise. The most important part after surgery, once we've held you immobilized for a period of time, is regaining range of motion. You have a golden period, the first 3 months in which to get your motion back, but you have the rest of your life to strengthen it. So we really focus on range of motion initially. Once you've healed, then we want you to minimize the chance of it tearing again. So we ask you to avoid repetitive overhead resistance activities. Those are the worst things. And then when we think about expectations after you have your rotator cuff repaired, or if you have non-operative treatment with physical therapy, our goals are the same. And whether it's done arthroscopically or as an open procedure, our goals are the same. To provide comfort, have you regain your range of motion and your strength, and most importantly, to be able to return to your sports. Thanks. I guess I'm not supposed to. I'm sorry, I have to go to the operating room.
Thank you.
So we want to, I know that there was maybe some questions that you all had relating to those type of injuries, or maybe specifically for Dr. Nutting. Several of us here can address, sorry for those at home, my phone is off. For those of you who have questions for Dr. Nutting or about shoulder injuries or rotator cuff injuries, we will be able to take those questions at the end. We're going to save all of our questions for our panel of speakers at the end. There are several of us here who can answer those. If you have something specifically for Dr. Nutting, we'd be happy to take those questions via email, and we can get back to you specifically. I also failed to acknowledge our home viewers tonight. We are broadcasting live via the web, so thank you very much for being with us. And for those of you at home who have any questions as well, you can send those in to questions at hitchcock.org, and they will be monitored and fed to us here in the room for the end. Now that I have all those housekeeping things out of the way, we have Dr. Christine Carlson, who is next. She's not only a former Olympic athlete herself, she's also been an Olympic physician at the Beijing Olympic Games. She's going to be talking specifically about concussions and how those affect our winter athletes.
It's on. Thanks, Molly. Switching a little bit to something non-orthopedic. I'm a non-orthopedic surgeon. I'm a primary care sports medicine doc, and I am the lead person in the sports concussion program here in sports medicine. I'm not here to recruit you to come and see me as a patient. So I just want to talk about concussions in winter sports and just thinking about, we think about concussions in summer sports, we think about concussions in kids and their high school teams and then in the college teams, but it's a lot more people in the winter, and it really is not just those organized sports. We think of skiing and hockey. Basketball is a huge source of business for me, but what about the fall on the ice? Those people are getting concussed too, and I think one of the problems with that is that a lot of the adults who are concussed are really good deniers. And hopefully I'm going to turn you into less of deniers should you or your friend or family member get a concussion this year. So, take home point number one. This is of 8, so you know how long I'm going to talk. Take home point number 1 of 8 is the guy on the left is probably at higher risk than the kids on the right, especially if he didn't have a helmet on. I thought when I first pulled this off about he didn't have a helmet, but I believe he does have a helmet on. So, how do people get concussed? This guy is ready, waiting for concussion. You don't have to hit your head. So he might not hit his head when he goes down. He might just end up sitting hard on his butt. But he had a whiplash type injury to his neck and his brain sloshed around inside there. So it's a myth that if you didn't hit your head, you didn't have a concussion. So I think that's really important to take home. Yeah, most of the time it is a hit to the head. It's an elbow to the head in basketball. It's some sort of, object hitting the head or head hitting the ground, but it's not always. And the rotational force makes a big, big difference. That is, when the head goes down, especially if there's anything from the side, that rotational force is really going to slosh that brain around. One of the things I talk about when I see the kids who've had a concussion is the unexpected hit. This guy, here he is, walking down the street with his cup of coffee. He should have known better, because if you look at this, what has he got on? He's got on these regular old sneakers with nothing on there and it's slick. But anyway, he should have known better, but he's unexpectedly fallen. And that's what I see a lot is when I talk to the kids who've been injured, they didn't see the other person who was about to head the soccer ball. They didn't see the end, and they ended up having a concussion. If you're ready for it, you're sort of brace your head and neck, you're going to do better. So basically, it's any fall on any slippery surface, of which there are a lot, hopefully not tonight on the way home. What about helmets? So I put required. Of course, it's not required for those adults going out and playing pond hockey, but it should be. You should really think about, if you're going out with skates on your feet, and that's folks going out skating on Ockham Pond as well. If you're going out with skates on your feet, you ought to have a helmet on your head, because you're likely to have those feet go out and your head go back. So there's a lot of folks who are out there without helmets. Hockey, the kids have to wear helmets. Skiing, I'm really encouraged to see how helmets have really taken off, how people really are wearing their helmets. What about which helmet? There's a lot of, we had something, I also take care of athletes at the college, and one of the parents, a friend of a parent of a lacrosse team said, we can supply our special helmet insert to the lacrosse team for free. Isn't that a great deal? And we in sports medicine sort of thought about it and said, no, that's not a great deal because this person's going to go and advertise. The Dartmouth lacrosse team uses our helmet inserts and they didn't get any concussions. Probably had nothing to do with the helmet inserts, and we didn't want to be part of their marketing campaign. So special helmets, not worth your money. You should just get a regular old helmet that is approved. There's several organizations that approve helmets. Doesn't have to be pretty, it just has to be functional. They do need to be replaced periodically. Talk about bike helmets. If you've been in a bike crash, you should replace the helmet. Same thing for skiing helmets. Helmet add-ons, the sort of padding that goes on the outside, or like this thing I was talking about on the inside, really are not worth your money. So, take home point number 2. I'll read it, but no helmet prevents concussion. They can help turn a potentially lethal head injury into a concussion. More likely to prevent a more serious brain injury, and don't spend extra money. What do I mean by that? The helmet is supposed to take the person who should have died from hitting that tree skiing and turn that brain injury into a concussion. So that's worth it. If they have a concussion, great, good for them. But they could have died if they didn't have the helmet on. So what about recognizing a concussion? I think this is key, and this is important for adults who are injured in a fall on the ice. Symptoms might not happen immediately. You might fall on the ice and go, yeah, I think I'm okay, and then maybe I'm not as okay as I thought, and that could be hours later. So paying some attention to, I don't quite feel right. I got this headache. That's right, I did take that fall skiing this afternoon. You don't have to lose consciousness. So, I didn't lose consciousness, so it wasn't a concussion. No, that's not true. We used to have a grading score of concussion. This was a this bad concussion, this bad, and this bad. And you know how hard it is trying to figure out if somebody really lost consciousness? Number one. Number two, for how long? It's basically impossible to figure it out. So fortunately, all of the loss of consciousness was dumped from the grading scale, which is really a huge relief to us. Really looking at symptoms in 4 different general areas: migraine-like symptoms, sleep symptoms, emotional symptoms, and concentration or schoolwork. So in the migraine-like grouping of symptoms, headache, light and noise sensitivity. The person who has migraine likes to be in the dark and they don't want to hear loud noises. Nausea, a lot of times migraine people can be nauseous, and that fits with the migraine-like cluster. You don't have to have, you can have like 1 from category A and 3 from category B, that sort of thing. The second cluster is sleeping too much, not being able to get to sleep, sleeping too little, so some sort of sleep disturbance is common in those who've had concussion. Emotional. I don't see a lot of emotional stuff, and when I do, it's sort of odd. I actually had a gal at the college this afternoon who was concussed in a game this weekend, and said she started crying right away. For no apparent reason, she started crying. And it's this sort of inappropriate crying, or sometimes the parents will say when my kid is just way more irritable than usual. They're not their normal self, they're just edgy. And the fourth one is concentration, which is trouble remembering, fogginess. This is where school issues show up for our kids. This is where your work is going to be affected if you're an adult trying to sit at a computer. I've separated balance and lightheadedness into a stealth fifth category. Sorry about that. Because balance is really, really another way that we're looking at assessing concussions. People can feel off balance, they can be lightheaded, and that's one of the things we can sort of measure, and not in a perfect way, but we can try to measure. So balance actually sort of belongs back in migraine-like, but it's not migraine enough-like. I gave it a fifth category. Take-home point number 3. When in doubt, sit them out. So when I said that concussion symptoms don't happen immediately, you may not know whether this is going to be a serious injury and a significant concussion until hours later. If somebody takes a bad hit, takes a bad skiing fall, you should be done. That should be it for the day. If it wasn't a concussion, great, good for you. You didn't risk a second injury. So grown-ups, this is you too, and I keep saying this is for grown-ups as well, because we think about, so many times we think about concussion is just for kids. So, you decide that this probably is a concussion and you decide that you need to be seen. You might go to the ED if it's particularly bad. You think, I think this needs to be checked out in the ED. You might go to your regular doctor a couple days later. I don't know, it's just not right. I don't feel right. So when we see you, we'll say, all right, tell me about your history, what happened to you, did you hit your head, do you think you hit your head, did you have a fall where you almost hit your head? We're going to ask about previous concussions as well. What are your symptoms? We're going to go through those sets of symptoms, trying to say, okay, this person really looks like they're mostly migraine, or this person actually has more balanced symptoms. We're going to do a neurologic exam. And then this gets to my next take-home point. Evaluation may or may not include imaging. People think that they need a CT scan, that if they're in the ED, they're in the emergency room because they need a CT scan. And there's actually very specific criteria, and I think our ED here does a really fabulous job of using those criteria to decide who needs that CAT scan and who doesn't. And there's a set of criteria, and they look at the patient very carefully, and if they say you don't need a CT scan, you don't need a CT scan. They're going to be really very careful to make sure they're not going to miss somebody who actually needs one. So I like that. There's a lot of small community hospitals who have a moonlighter or don't have somebody who's emergency medicine trained who will say everybody who comes in with a possible concussion gets a CT scan, and that's a lot of extra radiation to a lot of people's brains. So I think being cautious about CT scans is smart. Sometimes people come to me and they're asking for MRI. They want MRI to be done, and we really very rarely, if ever, do MRIs. MRIs cost a lot of money, and unless you have what we call focal symptoms, that is symptoms that localize to one particular part of the brain, unilateral one-sided hearing loss, something that seems really kind of odd and one-sided, then we will consider MRI, but typically we don't. So here I'm going to cheat a little bit. My next take-home point isn't there. Okay, I never mind. It's almost there. I forgot another slide. So brain imaging, what are we looking for? If we're going to image the brain, we're looking for not a concussion. We're looking for something worse, something more serious than concussion. So we're looking for bleeding into the brain. You do not want to have bleeding into your brain. Because what happens when you bleed into the brain, now maybe you can see this pointer, but see these central structures? They're pushed off to the side. Brain doesn't really like that. It really kind of hates being sort of rearranged. And you get all kinds of symptoms. We call them the red flag symptoms. They are the kind of symptoms that any average normal person would say, that is not right, that person needs to be in the hospital. So you're not going to miss the symptoms of a serious shift in the brain. So you shouldn't feel like, oh no, I have to remember what all these things are. You don't. And there's a couple different kinds. You can see here, this is called epidural on the left. The dura, you can't see this thing. So here's the dura. This is the blue here. Dura is this fibrous tissue that surrounds the brain. Epi means on top of. Epidural means that the bleeding is on the outside of that fibrous tissue. This is where some blood vessels have torn, and that is critical. These guys bleed quickly. They go unconscious. They stay unconscious. It's very clear that something bad happened to this person. Subdural hematoma. Ronald Reagan had this, incidentally, when he fell from a horse. Subdural hematoma is underneath the dura, and these accumulate much more slowly. So the person sort of changes their mental status over days, not over hours or minutes. And then there's bleeding inside into the brain. So on CT, if you're going to get a CT of a concussion, you see none of these things. Zero, nada, the brain looks normal. So take home point number 4. Here's where I cheat a little bit. 4, just because you had a normal CT scan does not mean it's not a concussion. 4.5. Because you did not need a CT scan does not mean it's not a concussion. And 4 3/4, sorry. There is no imaging test to diagnose a concussion. So I think this is important. These are important take-homes. I see patients. I had a patient in my regular clinic come in and say, well, she was goofing around on the escalator with some friends at a conference. We won't say if it was lubricated or not. But she ended up having an injury, and she went to an ED in another state, and they did a CT scan of her head, and she came in 2 weeks later saying, it's just not right. I just don't feel right. I don't feel right. But I know it's not a concussion because I had a normal CT scan. I'm thinking, okay, well, I got to start at stage 0 here and do a little bit of education. There really was a concussion. She had all the symptoms of concussion. She had a normal CT. And for 2 weeks, she'd been thinking that I must be fine because the CAT scan was fine. So I think it's a really important take-home point because people come in all the time saying, what about the CAT scan? I had an argument with a mother on the phone with Dartmouth kid last week. I want the CAT scan. Why? Because somebody in my community died from a concussion. Well, actually turned out to be not a concussion, it turned out to be a brain aneurysm. Nothing to do with concussion. She was all worried. So I spent a fair amount of time talking people out of that. Okay, so treating concussion. When I see somebody, what are we going to do with this person? How do we treat them? What is our treatment? Because you're thinking, okay, how do you heal the brain? You heal the brain with brain rest. Brain rest means I shouldn't be looking at the screen if I have a new concussion. I should be sitting away from screens. I certainly shouldn't be looking at that small screen of a cell phone. And that is just sort of taking you away from things that are brain irritants where you have to read, where you have to concentrate. And this is hard because this is taking kids out of class. What's also not new is physical rest. We also tell them you cannot exercise. I don't care if you're on a sports team and this is your major competition week, you're not exercising this week because increasing the blood pressure, increasing blood flow to the brain can irritate it if you have a new concussion. We also emphasize sleep. That is, I tell people that sleep is crutches for your brain. If you have an ankle injury, you're going on crutches. If you have a head injury, you're going on sleep. And just to think of it as your brain is just craving this downtime, just let it shut down and let it sleep. And actually, a lot of times people come in and they have been sleeping a lot. Okay, that's really great. Can you sleep more? And this, of course, gets in the way of your job, gets in the way of the kid's school, but it is so important early on. What's newer, that we're talking about a lot in national meetings is so-called return to learn. Return to learn is, so you can't take somebody out of class and say, okay, you're going to sit in that corner, you're going to do nothing in the dark for a week, and then you can go back to school full time. Same thing for our adults. You're going to go and you're going to lay low, you're going to sleep a lot. Okay, work full time, 8 hours. There has to be some sort of transition program towards that return to work, return to learn. And the transition looks like, first they start with 15 minutes of reading. You look at your screen or you're looking at your book, you read for 15 minutes and that's about it. And then, take a break. And that could be it for the day. Once you get to 30 minutes or so, then it's okay to start transitioning back to school or work, but you're not going to sit in front of the computer 8 hours for the first day back if you're an adult going back to work. You're going to go back, you're going to take some significant breaks. So this transition, which is kind of what we've been doing for transition for return to play for a long time, but now we're trying to structure a little bit return to learn. The schools all want, how do I do this? When do I send them back? How do I send them back? Give me the nitty-gritty. The other thing that's new, sort of new in concussion, is that doing zero exercise is really hard. Anybody who's ever tried to keep a 9-year-old from doing anything would know that it's impossible to keep them from climbing on the sofa or doing whatever. And parents come in and they go, oh, I'm a bad parent because I haven't kept my 9-year-old tied up and doing nothing. And the answer is, it's probably okay to be somewhat physically active. We actually think that after about 3-week mark, adding in exercise may be helpful in terms of those people taking a long time to get better. So it's not necessarily true that you can do nothing. You can go for a walk, probably is fine, as long as you're not getting worse headache, you're not getting worse symptoms from whatever you did. Take-home point number 5, return to learn, is progressive learning challenges. Like return to play, you don't progress until you pass the last step. Return to play is you have to pass each step. And I don't know if Molly, the slide's going to be available?
They won't, but I can make them available to you.
Okay. I just have a couple of, if anybody's interested, they could contact Molly, and I have a couple of links here. This is a link to the Brain Injury Association of Vermont's Return to Learn protocol. It's really great. I give it out a lot. And now the part of the take-home point as adults, this is you too. You can't just go right back and sit at your computer and expect it's going to be fine. So I see a lot of people who aren't getting better. The reason that they come to the sports concussion program to the consultant is because they've done all this stuff and they're not getting better. And it's week 3 and they're going, why can't I get better? What's missing? Something's wrong here. I must need the CAT scan. And yeah, so what I look at is, okay, what are we missing here? We must be missing something. Sometimes it is the quality of their sleep. That is, the sort of screwed up, addled brain is just going, I can't figure out how to go to sleep. And sometimes people need sleep aids. Benadryl is a great sleep aid. I use other sleep aids, but sometimes you need sleep, just like the overstimulated kid. They need sleep. They're like ready to crash, but they won't go to sleep. Your brain won't turn it off. So improving the quality and quantity of sleep can make a difference. For my collegiate athletes, it's the quantity of sleep commonly. They're staying up too late. Some of the high school kids, same thing, staying up too late. Sometimes it's the workstation, sometimes it's the computer screen. You want the screen to be as big as possible. The smaller the screen, if you're looking at a video on your cell phone, you are in trouble because that is, your eyes are trying to focus on a very small focal point and it's just too much for them. Whereas they may be able to tolerate that if it was on a big screen across the room. So I sort of, plug your computer into the biggest screen you possibly can and try and do your reading across the room, definitely not on your phone. Lighting needs to be similar to the lighting of the rest of the room. Looking at a computer screen in the dark is really bad for your eyes and just confuses your brain into, I don't know, not knowing whether it's light or dark out, but those people who are trying to not disturb their roommate and have their laptop open on their bed doesn't work very well. A lot of the people who aren't getting better, the answer is in their balance. That is, they are sort of off balance, and that balance is triggered just like you would be triggered when you are motion sick. Motion sick, you're triggered by all this visual input. They get triggered by the visual input of the computer screen. And so trying to make sure that it's not a balance and visual is worthwhile. And I send a lot of people to balance and vestibular physical therapy. There is such a thing. Donna Pigeon is a therapist here, does an awesome job with the patients that I send to her, and often that's what's missing. Sometimes it's this on the bottom, exercising too soon or too hard. And sometimes people have a heart rate threshold. One of the very first patients I took care of with concussion was a cyclist who'd been in a crash. And he basically had a heart rate threshold. If he exercised underneath his heart rate threshold, he was fine. As soon as he crossed that heart rate, whatever it was, he got dizzy. And we just had to kind of slowly increase his, okay, maybe now you can do a heart rate of, it took him more than months to get back. But he was exercising, he just had to beware of that threshold and not go beyond it. Here's another reason why some people aren't getting better. It's because it's not their head, it's their neck. Concussions, because you had a whiplash injury, may have also involved your neck. And typically, this isn't enough to require imaging of the neck. You didn't go to the ED and say, oh, it's my neck. You went in and said, oh, it's my head. But if the ED has any concerns, believe me, they're very good at deciding who needs a neck imaging. If you have a neck injury, muscle injury, this can be a real cause for persistent headaches. So sometimes we see people who the only remaining symptom is headache, and they're being held out, can't do your sports, can't participate because you still have a headache. Well, in fact, the headache may not be from their head, it may be muscle tension headache from their neck. So we have them consider physical therapy, and I want to teach you my next take-home point. This is my very favorite neck stretch. I want everybody to try it. So this is, I call this the headrest stretch. You imagine yourself driving, putting your head on the headrest and keeping your eyes on the road. Your chin is going straight back, your eyes are staying facing forward. So what you're doing here is you're stretching back, behind, you can go straight back, and then you can tip and tip. You do a really nice stretch of the muscles in the back of your neck if you do the posterior glide first, the headrest stretch. So that's take home point number 6. Return to play. I mentioned return to play already. Here's another link, but the CDC has a great website, a part of their website. If you go into cdc.gov and you put in concussion, or you put in Heads Up is the name of their program. They are celebrating 10 years of this particular website right now, and they have this structured return to play. It's 5 days or 5 steps. If you can't complete the step in a day, then it's longer than a day. Example is, you don't have hockey practice every day. You only have hockey practice 3 days a week, so you can't go through all of the progression steps unless you've done that particular step. You can't move on. If you get symptoms on one day, you stay at the last day or progression that you can tolerate. So sometimes it takes longer than 5 days. You can't do 2 days in one day. So this is a point for adults. Take on point number 7 is adults, you can't just go back to pond hockey the next day after your headache is gone. At least you shouldn't. Because you really should do a graduated return to play. So I get a lot of questions about this, and this is my last part of the talk, is how do we decide how many is too many? When does the pop-up timer go up? Ding! You can't play anymore because you've had too many concussions. I get a lot of questions about this, particularly from parents. Is it 3 and done? Well, he's had 2 previously, so this must be his last one, right? And the kid's going, please no, please no, I'm about to hockey. Is it 4? Is it 12? Is it 16? Is it 1? So I just want to share with you 2 cases. This is in the recent past, and just to illustrate the kind of range of return to play disqualification scenarios that I have been dealt with in the recent past. Case number 1 is a collegiate lacrosse player who is on documented concussion number 4. He clearly had this concussion clearly happened several weeks ago, and he is now less than 2 weeks into this concussion, and he is fine. He is 100% participating in all of his activities at school. He passed our impact test, which I didn't mention the impact test. We can talk about it in the question and answer if you want. He has done everything, and he is ready to go, return to play. Oh, but by the way, he probably had maybe, I don't know, 16, 18, we don't know how many hits when he was playing PB hockey. So when he was a little kid, he said, oh, I was kind of a little kid, I got hit a lot, and I had my bell rung and I saw stars. So I'm thinking, okay, so this is 4 or is this 24? I don't know. So I let him return to play because he had, each time he had a concussion, documented concussion, he had a rapid return to 100% normal, very short period of time, and I didn't see any reason why he should be held out. Case 2 is a high school hockey player who is on concussion number 2. She had a concussion 2 years ago, which kept her out of school for a month. No school, whole month. She then slowly returned to play, but she never made it back to hockey season because it was over. The following year, last year, she got out on the ice and she was too dizzy to even skate. She sat out all of last year. And now this year, she's sustained a concussion in field hockey. She's been out already for between 2 and 3 weeks. She's just getting back to going to school. So what do you think I did with her? Do you think I sent her back to play? Yeah, sure, hockey season is starting really soon. You can go back, have at it. Because you're going to be better by then than hockey's, it's only a few weeks from now. And I think you'll be fine by then. No, she was disqualified. I said, you may not, you're done. You're done. At least for this season, you're done. And potentially, permanently, you're done. Because she had proved that she took a very long time to get better from her first concussion, maybe never got better. Now she's got a second concussion and she's still not better yet. I don't care if it's number 2, you're done. So these are just 2 drastic cases, and these are real cases that happened to me within the last month or 2. So I think this is a really hard decision. So take home point number 8 is there's no evidence-based rules on disqualification. We make these decisions based on our best judgment and the best interest of the athlete. We take into account how long it's taken for them to get better. We take into account the interval since the last concussion. We take into account the injury mechanism, because sometimes the injury mechanism becomes lesser and lesser and lesser and lesser. They just got jostled outside their locker, didn't have their head hit anything, and all their symptoms are back. So This is a really hard decision, and I've illustrated 2 cases that are pretty drastically different, both of which I thought were pretty straightforward, and most of the cases aren't that straightforward. So finally, I'm done. These are some resources. The cdc.gov/concussion/heads up. This is the 10 years site. This has everything for everybody. It has stuff for me, the clinician, has stuff for you, the patient, the parent, the teacher. There's a section there for everybody. And then last thing is, when we do concussion education, we give the parents, while a kid is off doing their concussion tests, we give the parents a link to this YouTube video. This is called Concussion 101. It's a whiteboard talk where the artist is just doing like this and erasing and doing like this and erasing. It's 6 minutes long. It's awesome for concussion education, just to understand what a concussion is. You can go to YouTube. You don't have to watch all that. You do all that. I see people frantically writing down. Go to YouTube and put in whiteboard concussion or concussion whiteboard, and you will get here. Thank you.
Wonderful. Well, thank you so much, Dr. Carlson. I know that's really educational for a lot of people. Just a reminder that we will have question and answer at the end of all of our speakers. I am very hopeful and optimistic that Dr. Cole will be able to join us. After all, I still have a little surgery stop on the computer, and with any luck, there's not another one anxiously waiting right behind. So if not, I'm a poor substitute, but I can certainly manage. Next we have Jason Godsell, who's one of our physical therapists located at the Dartmouth Hitchcock Road facility. He also sees a lot of our orthopedic patients on the clinic side as part of our orthopedic office. So when they come in to see one of our doctors, we'll often see them as well. He's also a certified strength and conditioning specialist and has a special interest in the sports and athletic-minded people specifically. So with that, Jason.
All right, so thank you, Molly, for inviting me to speak. Thank you for the Department of Orthopedics as well. So my talk's going to be just a little bit different. My talk's going to be centered more on keeping you injury-free rather than dealing with an injury. So first, to do that, you have to talk about how to come up with an injury prevention strategy. And the first part of that is identifying first the incidence of an injury that happens to a particular athlete doing a particular sport. Then we identify the risk factors for that injury, followed by trying to design interventions that lower the risk of sustaining that injury. And then you can also test the interventions as well. So for this talk, I'm going to focus on injuries that are considered preventable. Not all injuries are obviously preventable. And then we're going to specifically talk about alpine skiing, snowboarding, and ice hockey. So we're going to first start with alpine skiing, right? And as we see, most injuries to skiers are to the lower extremities, right? With about 35% of those being to the knee. If we look into that a little bit further, we see about 50% of knee injuries in skiers are injuries to the ACL specifically. Upper extremity injuries are much more rare to skiers, with the most common being something called gamekeeper's thumb or skier's thumb. It's injury to the ulnar collateral ligament of the thumb based on using your palm. Okay, so the injury risk for ACL in skiers, also MCL injuries as well, has been studied in the past. The first study that came out a little while ago was on recreational skiers, and they identified 2 mechanisms. Those were landing back-weighted, and when a skier does that, a recreational skier, when they're falling landing back-weighted, there's 2 effects that are thought to create high levels of ACL strain, and that's one thing called the boot-induced anterior draw, and also an eccentric quad contraction. So when you land on your ski tails, the forces from the boot are transferred to the knee, creating a higher shear force. Another thing is called a phantom foot. What this is when the skier is falling backwards, the outside edge, the inside edge of the downhill ski will catch the snow, and the knee is forced into internal rotation based on a phantom foot phenomenon. So if we look, there's another study done on ski racers specifically, and they identified 3 mechanisms in this population. One of them is called the slip catch mechanism, which we're going to talk about a little bit further. That happens in about 50% of ski ACL-related injuries in this population. They also identified the landing back weighted and something called a dynamic snowplow, where the uphill ski actually catches the inside edge, kind of forcing the person into an internal rotation in the knee as well. Very mimics basically when you're doing a snowplow down the slope. So if we look at that slip catch mechanism, the reason I wanted to look at that one is that it's not during a fall necessarily. The skier is unbalanced when turning, however. So as we can see in this picture B here, the skier gets off balance, the outside leg comes off the snow. They try to reach to put that outside ski back on the snow, and their knee is extended. And so when they hit that inside edge on the snow, the ski abruptly catches the snow and forces the knee into that internal rotation position. So we look at that a little bit further here. With the advent of the parabolic skis, when that outside edge hits the snow, it automatically wants to turn. It does make a easier turning mechanism, but it also creates this increased internal rotation and valgus loading of the knee, and that creates high levels of force to the ACL of the skier. So with those risks, we want to now design interventions to help lower your risk of sustaining that injury. And everything is really centered around control of this internal rotation and valgus loading of your knee. So there's many different ways to exercise to work in this direction. One of the ones that has been most efficacious is balanced and proprioceptive exercise. Right? So doing things that put you in a ski-specific position on an unbalanced surface. And also one thing that should be added is perturbations. And that could be through a partner, that can be through tossing a ball, or anything that creates an outside force where you have to adjust to it. We also have strength training, which is a very important tool because skiing requires high levels of strength to control those forces, to control your turn. We want to stress also trunk control. So obviously, most of these injuries happen when you're off balance or losing control. So if you can help correct that, a lot of times you can correct injuries downstream. And then the last one is plyometric or jump training. Right? This has shown a lot of improvement in risk levels of people sustaining non-contact ACL injuries, especially in sports like soccer, skiing, things like that, where there's no one hitting you. And one thing I want to stress is that the landing technique is the most important. It's not how high you jump or how far you jump. It's how you land. So if you land very softly, don't hit the ground very hard, and you control that internal rotation of your knee, you're lowering your risk of sustaining that injury. So then we're going to switch gears. We're going to head over to snowboarding. And one thing we see when we study the incidence of injuries in snowboarders, we see a significantly larger amount of upper extremity injuries than lower extremity injuries in the recreational skier. In competitive, professional snowboarders, we see actually more knee injuries, less wrist injuries because they fall a little bit less. Second most common injury to a snowboarder is a shoulder injury, a soft tissue shoulder injury, with rotator cuff strains being the most common one. And the mechanisms that have been proposed for snowboarders and shoulder injuries, more specifically, are falls on outstretched arms, collisions, and as well as an eccentric load to the shoulder as the boarder resists abduction. So basically the boarder is off balance or falling and tries to catch themselves and control the rate of descent, creating a large load to a smaller muscle group in the shoulder that's not strong enough to withstand that load. So prevention of rotator cuff strains, we want to really focus on the smaller muscles of the shoulder. mostly the external and internal rotators. So with snowboarding, there's high velocities and high impact forces. Most of the falls are taken to the upper extremities. So there's a need for a high level of strength and endurance in this group. One thing I want to stress, though, is when you are exercising this muscle group, only about 40% of maximal contraction is needed to really get the right activation. All right, so think of that as lower repetition, lower resistance with higher repetitions. If you bring the load up very high for things like internal and external rotation, you're going to get the bigger muscles that are going to be activated. They're going to compensate, and the smaller ones that we're trying to strength train to decrease the risk are going to be used a little less. When talking about the shoulder, we always have to kind of add in the scapular aspect of this. Research has shown that isolating fatigue of the scapular musculature has led to alterations in the shoulder motion, which therefore increases your injury risk. These are some of the muscles of the scapular musculature. Not all of them, but they're considered the finer points. So the exercises you want to do for scapular training specifically are rowing type exercises, prone exercises, horizontal abduction where you bring your arm out to the side, things that really engage the muscles around your shoulder blade. So we're going to switch to ice hockey now. And when we study this population, we see that most of their injuries are actually sustained at the end of games. Actually, one thing I've found through doing a little bit of research is this is actually a relatively low injury risk sport, which I think most of us wouldn't suspect. They actually have a lower risk of injuries or lower amounts of injuries than soccer. So when we look at this group, we see obviously the most injuries are contusions or bruises, which is pretty consistent with the type of sport they play. And the second most would be sprains or strains. And we're going to focus mostly on those adductor muscle strains. So that's the inside muscle of your thigh. It's the second most common injury in hockey, ranging anywhere from 17 to 40% of all hockey injuries. So a landmark study for hockey players was in 2001 by this group out of NISMAT, New York City. They found that there was a large association between hip adduction strength and adductor strains. They found that you are 17 times more likely to sustain an adductor strain if your adductor strength is less than 80% of your abductor strength. All right, so up at the top there, the person's testing the adductor strength. That's this muscle group right here. And then at the bottom here, they're testing your abductor strength. That's this muscle group right here, to be able to bring the leg up. So the arrow is just the force of the person, but the person's laying on the other side. So this thigh, this is the right thigh, and this is the left. So normally, people that don't get adductor strains, their strength ratio is about 95%. So there's a significant reduction in the strength. So they followed that study up with a second study the next year, and they tried to come up with an injury prevention program for this group, focused specifically on targeting that risk factor, so strengthening those adductors. So they used all of these exercises for this group, and it was a professional hockey team, so they had quite a few resources. But I'm going to just show you a few that I thought were the most indicative of preventing injury. So the first one here would be things like side lunges, right? So you're working both the concentric and eccentric phase of the muscle contraction in a lengthening state, in this exercise here. This is another good one, easy one to do anywhere basically, or basically adduction against resistance. And it can be elastic, it can be a cable column, you can do it on your side with a weight, you can do it on the bed with a pocketbook, it can be done anywhere. The last one here is a little more advanced, but it's great for hockey specifically. It's something called a slider. You're basically sliding out to the side, right? This is the starting position, sliding out to the side, and then sliding back. So the person's foot is on something called a valley slide. You can really use a paper plate on a carpet or anything like that. A furniture mover works just as fine too. But the key is that this is very similar to the hockey motion, or the skating motion, not hockey motion. The adductor muscle group is this group right here, and it controls the rate of abduction when you're skating. So they did this study after this team had indicated that they had a lot of adductor strain. So prior to implementing this exercise protocol, they had 11 adductor strains the season before. And then after implementing this protocol, they only had 3. So the incidence dropped from 8 to 2% per season for a professional hockey team. which if you think of how many games lost, practices lost, that's quite a few. So the last thing I'm going to show you is, if you don't even play those sports, that's fine. We're going to talk about this study. This is a very large meta-analysis, reviewed all injury prevention studies and sports injuries specifically, and they found that stretching offered very little to no protective effect, which is pretty commonly found in the literature. Proprioceptive training, which offered a moderate effect towards risk reduction, and strength training offered a significant effect towards risk reduction. And their biggest take-home point was that strength training reduced sports-related injuries to less than 1/3. And these are all the references I have. If everybody wants those, they can just give Molly and send those out.
Oh boy, ladies and gentlemen, not only does he operate, he knows how to do technology. By the mysteries of medicine, Dr. Coe has managed to join us from the OR, and not only that, but he even changed, which is like amazing. Dr. Marcus Coe is one of our lower extremity orthopedic surgeons here at the hospital. He's going to be talking about the more traumatic injuries of the knee, foot, and ankle.
Evening, everybody. Very sorry that I'm late, but glad I could make it. So I just picked a few injuries that we see relatively commonly throughout the winter to talk about. There are a lot more out there, and I'm happy to field any questions I can about more specific injuries moving forward. So here's what I laid out just to talk about briefly. So we're going to talk about meniscal tears in the knee. We're going to talk about ankle fractures, ruptures of the Achilles, and then we'll stop with tibial shaft fractures. And really, I go from the top to the bottom of tibial fractures. So we'll start off with meniscal tears. So this is a view of your knee. This is the bones in your knee. This is your right knee looking from the front. Here's your kneecap, your patella, the fibula, the tibia, and the femur. And if we cut this in half and then look down from above, this is the view that we'd see. We're talking about these two structures that live on either side of your knee. This is showing the ACL and the PCL section here, and this here is the tear of the meniscus. So what is it? What are these things? The menisci are two bumpers, essentially, that live in your knee, and they have a couple different functions. One, they spread out the force in your knee, and they provide some degree of restraint. But predominantly, they're acting to spread out some of the forces that you see with load bearing. And you have one on the inside and one on the outside of your knee. Some of the other structures that you see here that you commonly hear about, ACL, PCL, and the collateral ligaments on either side that stabilize the knee. So the meniscus is interesting because only a certain part of it has the ability to heal on its own. So if we look at the picture down here on the bottom, this is looking again at cut through the top. And you can see that the meniscus goes from red to white. And that represents the area of the meniscus that gets blood supply from the outside. So the blood vessels live on the outside of the knee, and they send blood vessels into the meniscus, but they only make it about halfway. And the inside of the meniscus gets all its nourishment from the synovial fluid that bathes it. And consequently, it can't heal because it doesn't have blood supply in order to bring all the factors that it would need to heal there. Meniscal tears come in a bunch of different flavors. The upper right-hand corner shows some of those different types of tears, but they can essentially be lumped into those that are associated with injury or traumatic tears, and those that are associated with degenerative tears. So either something acute happens and you end up with a tear, or the wear and tear in your knee creates essentially a rough surface that eats away at the meniscus and can cause tears. So if we're talking about acute tears, how can those happen? Typically it's with some sort of hyperextension or deep flexion injury somewhere at the extremes of motion of the knee. It can be a twisting injury, and again, that wear and tear can happen just with arthritis in the knee. So this is a little bit of what it looks like. This is looking inside with the arthroscope. On the left here is what a normal meniscus looks like. This is the femur up on the top. This is the tibia on the bottom. And this structure here is the meniscus on the periphery. And that's a nice, clean meniscus with a sharp edge. And you can see here there's an instrument that's been introduced that's hooking around a tear and pulling it into the joint. And essentially, we think about it kind of like a pebble in your shoe. If you have this piece of or flap of meniscus that's moving in and out of the joint every time you move it or walk, it can be painful and potentially damaging. So how do you know if you have it? Typically, people with meniscal tears have pain right on the joint line. So it's typically either on the inside or on the outside, and you can pinpoint it right to one place right there. And if you go into one of our offices, typically someone cruel will push right on that place and make you jump. The other way that you know you might have a meniscal tear is what we call mechanical symptoms. So catching, popping, locking. If your knee sticks in one position, you kind of have to move it, and there's a thunk, and then it goes back to moving okay. That's a pretty sure sign that you have a meniscal tear. People ask about popping and kind of crepitus or Rice Krispies all the time in their shoulders and their knees, sometimes in their hips. And in general, those kind of like little pops and clicks that you feel without pain are perfectly normal. What makes them happen, I don't really know. I've heard all sorts of things about vacuum phenomena, but the long and short of it is nobody really knows. It's essentially the same thing as cracking your knuckles. And swelling. Typically, if you get an acute meniscal tear, your knee will blow up because it's been filled up with blood. So how's it treated? A lot of that depends on the location of the tear, how old the person is, any associated injuries, and the presence of arthritis in the knee. Because once you have arthritis in your knee, you have a meniscal tear associated with it. A lot of instances, the cow's kind of already out of the barn, and dealing with the meniscal tear won't necessarily deal with the core problem of degenerative changes. So the most conservative end of things, physical therapy and injections with things like steroids or sometimes viscosupplementation can help calm down a knee. Well, it may not cure a tear that's in that area that won't heal. It can make it less symptomatic and allow people to get back to what they need to do. And then there are two basic surgical options, either cutting out the torn meniscal fragment, which is probably done a lot more commonly, or repairing the torn meniscal fragment. So physical therapy we touched on a bit. This is an injection into the knee, not necessarily done with physical therapy, but both of those have the potential to provide significant relief, especially if you have a degenerative meniscal tear associated with some arthritis. Again, we talked about kind of cutting out that pebble in your shoe. Here you can see this rough torn edge. And here's what it looks like after instruments are introduced into the knee to bite away at it. If the tear is outside the area that will heal, it's a certain type of tear pattern, or degenerative tears, oftentimes those are treated with this sort of procedure. And again, this is done much more commonly. And And then sometimes that tear is repaired. So this is what's called a bucket handle tear. If you imagine in 3 dimensions, this can kind of flop in and out of the joint. And if it flops into the joint, it can stick in one place and your knee can get stuck in that position. Especially if these are acute tears, if they're in the right position, so they're in that red zone where they can heal. Oftentimes these are treated with repair. This is just a little drawing of how that's done. There are lots of gizmos out there, but it's some variation on placing sutures or suture anchors across the fracture, or excuse me, across the tear and allowing it to heal. The difference between these two, if you have your piece of meniscus torn out, people usually, sometimes within a day, oftentimes, most often within 2 weeks, are back to normal, their pain is improved, maybe not all the way, but most of the way, and they're back to doing what they want to do. If you need to have your meniscus repaired, it's a much longer recovery period. It involves a non-weight bearing period, oftentimes a constant motion machine. So there's a lot more rules. And then sometimes they just don't heal. All right, so ankle fractures, which can occur really in any sport, winter or otherwise. And actually, probably this guy has a tibia fracture, not an ankle fracture, but well on that. So what is it? So your ankle is composed of 3 bones. The talus, which is in the middle, and lower down in your ankle. And then the tibia, which comes down and forms what we call the medial malleolus on the side here. And then your fibula, which comes down and forms the lateral malleolus on the outside of the ankle. So tibia and medial malleolus on the inside, fibula and lateral malleolus on the outside. And it's in conjunction with that, when you injure your ankle severely, you can either break bones or you can rupture ligaments. And typically they're done in association, and usually it's one or the other. One gives way before the other one will. So how does it happen? Essentially it's a twisting injury on a planted or restrained foot. So this is just a little video that shows what happens if your foot's planted and you have this rotational force around it. And it kind of shows the way that the force travels around your ankle with the most severe type of injuries. This is just one type of ankle fracture, but it's illustrative of basically all the mechanisms for ankle fractures that we know. You can see there are fractures occurring, and then here you're going to see ligaments rupture on the inside. That kind of seals the deal and brings things 360 degrees around the ankle. So there's a whole bunch of patterns, right? Like there are a bunch of people who stuck their names in a bunch of different ways to classify these. But it's basically dependent on what position your foot's in and then the direction of force that goes through your foot at the time of the injury. Different patterns can provide different severity injuries. It's worth mentioning the syndesmosis. Hear a lot about high ankle sprains. These are essentially injuries to the syndesmosis. This is interesting because you can have what is essentially an ankle injury, ankle fracture, that presents with a fracture all the way up here at the top of your knee. The syndesmosis is the ligament that runs between the tibia on the inside of your leg and the fibula on the outside, and essentially stabilizes those bones both longitudinally and side to side. So you can have an injury to your ankle, again, planted foot, twisted, where the energy starts out on the inside of your ankle and travels all the way up through that ligament and presents with a fracture up at the top. So you can see here, there's no fracture down at the bottom here. The only fracture is up at the top. So this is still an ankle injury and oftentimes requires surgery. And a high ankle sprain is essentially a more modest version of this that doesn't have an associated fracture, but can take a very long time to recover from it and can be really recalcitrant to treatment. So how do you know if you have it? So these Ottawa ankle rules were created a while ago now, but they proved to be pretty effective at ruling out people who need x-rays. So if you hurt your ankle, and we'll start at the top here, you push on the outside or the inside of your ankle, you can feel the bone there that makes up your lateral malleolus and the medial malleolus. If it hurts right when you push on the bone right there, that means you need an x-ray. If you can't bear weight immediately after the injury, you set it off, walk it off a little bit, and then you still can't put weight on it, you need to go get an x-ray. That's what almost every emergency department in the country is going to use to determine whether they're going to get an x-ray for you. So you can kind of use it as a first line defense to know if something is bad enough that you need to have it checked out. So how is it treated? Really, it's based on the stability of the joint. You saw how the energy in that video went circumferentially around the ankle. If more than one of the restraining structures of the ankle are injured, then it becomes an unstable pattern and one that we know responds better to surgery than to non-operative treatment. Oftentimes, if just a single side of the ankle is fractured, you can get away with treating those in a cast and have similar results afterwards. And again, those injuries can be ligamentous or they can be fractures. And essentially, casting is some combination of usually a short leg cast and non-weight bearing for anywhere from 6 to 8 weeks. Surgery involves plates and screws to put the fractures back together so they heal, but it's your own body doing the healing, so it still takes 6 to 8 weeks usually until you're back to full weight bearing. So we'll talk a bit about Achilles tendon ruptures, famous ones and maybe less famous ones. These are two of the big sports that we see these with. So what is it? It's disruption of the tendon that inserts onto the back of your calcaneus and essentially allows you to plantar flex or push your toes down towards the ground. This is a depiction of it here. It goes all the way up and connects to two major muscles, one that attaches on the back of your tibia and fibula, one that goes all the way across your knee joint and attaches on the back of your femur. So usually this happens with an eccentric load with an extended knee. So basketball, racket sports, especially squash, are often culprits. It's typically someone a bit, middle-aged male, decides they're going to play in their company basketball tournament, and in the first game, they feel a pop. There are certain medications that can be associated with this as well. Steroids can cause weakening of the fibers of the tendon and can lead to rupture. And some antibiotics have been associated with it as well. Fluoroquinolones, things like ciprofloxacin, can be associated with tendon ruptures as well. How do you know if you have it? This is kind of a video here. That guy's squeezing that leg, and you see when he squeezes the calf on the left, causes the guy's foot to flex. But when he does it so that's the good side. When he does it here, you can see squeezing that calf causes no flexion of the ankle. And he's feeling for a palpable defect there, where you can oftentimes feel a divot from where the Achilles tendon has ruptured. Almost universally, if you're playing a racket sport, even if you're not, if you're playing with someone else, some people say that they thought that someone had hit them in the back of the leg, someone had thrown something at them. Oftentimes people feel a pop, it's painful, and there's weakness pushing off because that's the main muscle that helps you plantar flex your ankle. So these are important to catch early because we'll talk about this in a little bit, but the sooner that you can be casted in the appropriate position, essentially, or splinted, to bring those two tendon ends together so they're touching, the quicker you're going to get on the road to recovery, no matter which way you head. This shows someone who's casted in what we call an equinus position with their toe pointing down. And that's kind of where you want to be as early as possible after an Achilles tendon rupture. So how is this treated? This has gone through an evolution recently. So the old data would tell us that if you rupture your Achilles tendon, you treated it non-operatively, you had a higher rate of re-rupture, but a less chance of complication, which makes sense because you don't have to go through the surgical risks of bleeding, infection, and especially in these surgeries, risk of wound breakdown. Surgery came with a higher risk of complication, but less risk of re-rupture and greater strength. So that mainly was in the area of placing people in a cast and letting them sit there while things healed, and then taking them out of it and letting them go. What we know now is that motion, this is not surprising, motion is good for everything. Motion is good for cartilage, motion is good for ligaments and tendons. And so some of the best level 1 or the highest level studies that we have now would tell us that people who go into bracing an early range of motion with restriction on how high up you can bring your foot, so you're not separating those tendon ends, they live right next to each other and you're moving them together, those people will do just as well as the people who have surgery to repair them, and you avoid the risks. That includes strength. People, the best studies we have would say that the strength is the same when you come out the other end. Now, there are caveats to that, including how early this is caught. And nobody I know of has been, everybody's been too chicken to treat professional athletes that way because of the concern that they won't end up as strong. Because if once you treat it non-operatively, you kind of lost, once you get a couple weeks out, you've lost